Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can review some of the common therapeutic mistakes that counselors tend to make. So here I'm not talking about signs of a bad counselor, I've talked about that before, but rather just mistakes that I've seen in the practice of counseling. Now when I use the term counselor here, I'm using it more in a general sense, so professional counselors, but also social workers, psychologists, and anyone who uses psychotherapy as part of their practice. So I gave this some thought and I did some reading, and I assembled 6 counselor mistakes, 6 therapeutic mistakes that I've seen a few times during my experience as a counselor and as a supervisor. So these are fairly common mistakes, and they don't by themselves indicate that a counselor is not professional or a poor counselor. Again, they're just common mistakes that I've seen many times. So the first therapeutic mistake I'll talk about here is when getting a new client. So a counselor receives a new client, they come through intake. Some agencies separate intake and assessment. They assume that the last diagnosis or diagnoses that the client received, that those are correct. So really what I'm saying here is they skip the assessment phase. So a lot of times if intake and assessment are divided, in intake we see more perfunctory information gathered, like someone's name, address, date of birth, social security number, perhaps a list of recent employers, other information like that. And then when a client gets to the assessment phase, a counselor is really looking at what's the problem, what's going on, what are the symptoms, and what the diagnosis might be. So assessment's a little different than intake in a lot of agencies. So by skipping the assessment and assuming the last diagnosis is correct, really there's a lot of problems with this. One is the person could have a change in diagnosis. So for example, they may have alcohol use disorder with the original diagnosis, and they see a counselor now and perhaps it's in remission, and that's overlooked. You could have additional diagnoses, so a change or additional diagnoses, or the original diagnosis could just be plain incorrect. The counselor or other therapists that had that client before could have made a mistake. One of the popular ways of thinking that I see, popular cognitions in therapy, is this idea that you can't really challenge another counselor. So really this is a question of being too agreeable. So like agreeableness on the 5-factor model, for example, tending to overvalue cooperation and not be willing to stand up and say, look, I appreciate that you did your best with this diagnosis, but it doesn't seem to be correct, at least at this point. The second therapeutic mistake is taking awful notes. So these are progress notes. This is the note that's recorded for every clinical session, for every counseling session. And I've seen every excuse in the book for awful notes. It takes time away from therapy. If I take detailed notes, the supervisor will read them and then know information they shouldn't. A supervisor, of course, is allowed to read notes, and they really, from time to time, should if that's convenient in the situation. So that's a really bad excuse. Now, you don't need to write a book as a counselor, but there needs to be enough to figure out the theme. And I've seen some progress notes that just really didn't live up to that standard at all. For example, I've seen a note that says, client okay, oriented times 3. That was it. So oriented times 3 in counselor language means that the client knows who they are, where they are, and what time it is, approximately. So we call this person, place, and time. I've also seen another expression, oriented times 4. I don't use that one. I know some counselors do. That 4th item is the situation. So oriented times 4 would mean you have person, place, time, and the client understood what situation they're in. They understood that they were there to see a counselor about certain mental health symptoms. Another note I've seen is client talked, counselor responded. That's certainly brief, but I would kind of expect that from almost any session, so I'm not sure what value that adds. And I've also seen, and this is one of my favorites, client arrived and departed. Now, when I first saw that note, I thought that it meant the client came to the session and before anything really happened, they left, like maybe something went wrong. Maybe they were upset, or some other situation occurred and they left. But that was a 1-hour session. So really you just have the first second and the last second documented. Who knows what happened in the middle? Another one I've seen is client was normal. So again, that doesn't really tell me much. Client was normal. What's normal to them? And another one of my favorites is client was awake during the session. And when I read that note, when I first read that note, I was thinking, so is the norm that they're not awake? I don't know. It just seemed like an odd entry for a progress note. Usually when I write a progress note, it's somewhere between 6 and 12 sentences long. And it has information about the pattern and the general theme of that session. Not necessarily details, right? I'm not writing down dates of birth or exact names of people that the client interacted with, or something really technical and detailed that would reveal something that they may not want other people to know. Even though really not many people are supposed to be looking at a progress note, of course. But I do try to keep them general in that way, not necessarily indicating specific people and detailed information. But I do like to capture the theme. I want to be able to read that note and more or less understand what happened in that session. And maybe even by reading that note, I'll remember what happened in that session. And that helps for continuity, for the next session to kind of string the sessions along so that they make sense. So we're moving in a direction that's helping the client meet their goals. So now moving to the third therapeutic mistake. This one is when a counselor overreacts to a revelation. So when you work in the mental health profession, you're going to hear a lot of stories that may be surprising. It's information that people normally wouldn't talk about outside of counseling. I used to work a lot with individuals who had substance use problems, and sometimes they'd be hesitant to reveal how many DUI convictions they had, for example. And I've seen individuals who had 12, 13, 14 convictions. Now, when you first start working with people who have that many convictions, and of course many of those would be felonies, that's surprising. But you don't want to overreact to that. You don't want to have an amazed expression that really tends to shut down the sharing later on. As a counselor, you really can't be surprised by human behavior. Again, you're going to hear a lot of different stories, a lot of variety, and a lot of extreme stories as a counselor. And it's just something you have to get used to. Now, underreacting is a problem as well, of course. It's appropriate reacting that we're going for. But I've noticed as a therapeutic mistake that overreacting element, especially to revelations that the client is sensitive about, that tends to be a problem. Moving to the fourth therapeutic mistake I see, this is when somebody, a counselor, excessively notices nonverbals the moment that they happen. So if a client's sitting there with a counselor and the client puts their hand on their knee and the counselor jumps at that, what does that mean? You put your hand on your knee. Or if they cross their arms, or if they wipe their hand across their forehead or something like that, and the counselor draws all these inferences. For example, if somebody crosses their arms, a lot of counselors think that means they're being closed off, but they could just be cold. Or it could just mean nothing. They want some place to put their arms. So it almost becomes, I think, with this particular therapeutic mistake, a little bit smug. Like the counselor has this ability, like these superpowers, to detect what nonverbals mean at a really profound level, like taking a simple nonverbal alone and drawing a whole story from it. Now, it's one thing over many sessions if you tend to see the same nonverbal behavior. Of course, that could be important. But one single behavior or a few behaviors, you really can't draw too many conclusions necessarily from that. Another thing I see in the same area is when a counselor believes they have the ability to detect lies. So they will look at the client and say, I don't think that's true. Now, I've talked about this before in other videos. There's no way just by looking at somebody and talking to them to detect lies. Even lie detectors, even those machines, are really not reliable. So again, this kind of comes back to this idea of having a superpower. Now, making observations about nonverbal behavior in moderation, especially after a few sessions, picking up on themes, again, that's okay. It's jumping at it the second it happens and drawing a lot of conclusions that I believe is a common therapeutic mistake. So moving to the fifth therapeutic mistake. This is pretending to follow the story. So what I mean by this is a lot of times, especially if a client is new to a counselor, they're going to have a lot to say. Individuals in that client's life may not listen to them. They may have a lot of information they don't want to reveal to just anybody. They want to reveal it to a professional. And they're concerned about, again, the sensitive nature of that information. So when they come in, they really just start talking a lot. This doesn't always happen, but it's fairly common. And you don't want to cut them off, but you also don't want to lose track of the narrative. One problem I've seen, at least for me, is I tend to get confused when somebody strings together a lot of complex relationships in a narrative. For example, if they say, oh, this happened to my sister-in-law's cousin's ex-husband. Well, really, I'm really bad at relationships, so you already lost me at sister-in-law. So I'll stop a client in that situation and say, okay, you have a sister-in-law. Let's start there. That sister-in-law has a cousin, and that cousin was married to a guy, and now they're divorced, and we're talking about that ex-husband. I really need to break it down that carefully, or I lose track of those relationships really quickly. So again, it'd be, I guess, convenient to not break up the story if I didn't interrupt, but then I wouldn't know who the client was talking about. So a counselor really shouldn't pretend to follow the story. They need to interrupt enough to make sure that they are tracking it correctly. That's the only way that useful interventions can really come about, tracking that story carefully. So the sixth therapeutic mistake that I see in counseling might be a little bit surprising. And this one is when counselors don't admit mistakes. Now again, I'm talking about therapeutic mistakes here. So this is when a counselor makes a mistake and does not admit it to the client. This is actually, I think, missing a very valuable learning opportunity for both the counselor and the client. Counselors are only human, and they make mistakes too. And sometimes you can really help build that relationship by indicating that mistake was made. I think lately we see all this information about narcissism. This has been called the age of narcissism. But I don't think this really has to deal with narcissism as much as perfectionism. There's a legalistic kind of attitude, I think, in the mental health professions. Like counselors need to be perfect. And I think that the fear that counselors have here is if they admit a mistake, then someone will draw an erroneous conclusion. They'll think, well, if there's one mistake there must be a lot of mistakes, and they must be a bad counselor. But really, like I said, admitting mistakes helps everyone to learn. And I think it's actually one of the best signs of a good counselor. Now, again, everything has to be done in moderation. You wouldn't want a counselor that interrupts a session every few minutes and said, oh, I made a mistake there. Counseling isn't really that precise. It's a science, of course, but it's not that precise where you can look at every word and start overanalyzing it and get something useful. But if there are mistakes that are made, particularly over a few sessions, like if a counselor really isn't tuned in the way they should be, they're distracted, or they miss an important theme in the narrative, or the techniques they use really aren't working and they keep trying them, maybe one session too long, I think it makes perfect sense to have an honest discussion about therapeutic mistakes. So that's my list of therapeutic mistakes. I think that whenever we talk about counselors and different things they can do right or wrong, there are a lot of thoughts on this. If I missed any here, and I'm sure I did, please put those in the comments if you have any other therapeutic mistakes that you've seen or that you're aware of or that you believe are out there. As always, I hope you found this description of counselor therapeutic mistakes to be interesting. Thanks for watching.